I know, and it's good because my wife hates my coffee pot, so it's a great excuse to buy a new coffee pot, right?
That's right.
All right, so we left off just before starting induction of labor, so I felt like it was a wonderful time to start there. Induction of labor is, what is induction of labor? Well, it's the artificially beginning labor, okay? The rate of induction of labor is very, very high in America, and it's one of the reasons why our C-section rate is so very high as well. Because when you mess with Mother Nature, I promise, will try to make you pay for it. And so, but we have a lot of inductions in America. There is actually a protocol by the American College of Obstetricians and Gynecologists, and they say things like, maternal health, baby's wellness are wonderful times to induce labor. For example, preeclampsia, gestational diabetes after 40 weeks pregnant, oligohydramnios, irregular fetal heart rate tracings or category 2 tracings. All of those things are wonderful times to induce. Time it's not a good idea to induce, I'm 39 weeks, today's my due date, my doctor said I could have my baby today. Absolutely not. And a lot of people do because obstetrics is a business, and doctors want to be paid, and they want patients, and they want everyone to love them. So they give in and they induce, and then they just do a C-section after hours, so they're done. Okay, but the rate of induction, the rate of C-section among primiparous patients who get induced is 75% or higher. Okay, extremely high. May as well just flip a coin and cut them on admission. You'd have better outcomes. Okay, so but induction there's definitely a reason for it, but it needs to be protected. Has anyone heard that you can't get induced at WOMAC? It sure is true. We have the best reputation in town for you can't get induced at WOMAC. You got to force them to induce you at WOMAC. Yes, you do, because induction is evil. And I always tell people, I care about you too much to induce you. You never even met me. And think how much more I'll care about you when I take care of you in labor. I'm not going to do it. But anyway, so induction is bad. But there are some things that we need to know about induction. One, the Bishop score. What is a Bishop score? Anybody catch that? He asked me to read. What was it on the list? No, a Bishop score is a score that we use to grade how ripe the cervix is. Okay, a cervix that is greater than 6 on the Bishop score has a pretty decent outcome, or a pretty decent chance of a vaginal delivery. A cervix greater than 9 on the Bishop score has a wonderful, that makes the risk of labor versus induction is equal for C-section. So it's how soft is the cervix, what position is the cervix in, how far dilated is the cervix, what station is the baby, and how many times has the woman had a baby. So if you come to me and you're 3 centimeters dilated, 50% of face, -1 station, and this is your second kid, that's a chip shot. Well, we'll get you in labor like no big deal, have a baby, it's easy. You come to me and you got a cervix like a bottlenose dolphin, long and closed and rock hard and deep tucked up posterior, we need to ripen your cervix before we can go anywhere, okay? Because the cervix isn't going to change until it's ready to change. And so we have to use cervical ripening agents. There are several cervical ripening agents. The more natural type, like laminaria, which is just seaweed, we put it up in the cervix and it absorbs water and it forces the cervix open. Kind of cool, but takes forever. There are Foley catheters. We can put a Foley catheter inside the cervix, through the cervix into the uterus, inflate the balloon to about 4 centimeters, and then pull it nice and tight, and it forms a wedge that manually dilates the cervix from the inside out. It's a wonderful way of doing it. It works incredibly well, usually works in less than 12 hours, but it hurts like you wouldn't believe, okay? One of my midwives had a Foley for cervical ripening, and never called it the balloon again. From that moment on, it was always that damn balloon. And that was how she would counsel patients. Oh, we got side attack, we got vasopressin, we got that damn balloon. Which one do you want? Because it's very, very painful, very uncomfortable. Not so bad that most people are asking for narcotics or anything, but definitely not fun because you got this manual force that's forming a wedge in your cervix and forcing it to open from the inside out. And then we make it even better by pulling it real tight and taping it to the thigh, so it puts constant traction on it. And every hour or two we come and pull it tight and tape it up again and kind of force it out. You could use it alone, or you can use it with Pitocin to make the contractions help force it out. It works pretty good. Like I said, it's very safe. There are no contraindications to it. You can do it on anybody. We don't usually do it on someone who's ruptured, but you could. Okay? Then there's misoprostol. Misoprostol is Cytotec. Does that name sound familiar to anybody? Yeah, that was the drug for postpartum hemorrhage, right? What's the drug dose for postpartum hemorrhage? 800 or 1,000 micrograms sublingual or rectally, right? In induction of labor, it's 25 micrograms. 25. The normal dose you would use to take that pill if you were going to do like treat ulcers is 1 milligram. We give 25 micrograms for labor. It's an incredibly powerful drug for the cervix. But we take just 1/4 of a pill, we put it in the birth canal, and it makes mom contract like crazy and softens her cervix. You can also take it orally. We use 50 milligrams orally the first dose and 100 milligrams the second dose. But I find you get more bang for your buck if you put it in close to the cervix. The beautiful thing about Cytotec is it works very, very quickly. 4 hours, you get a pretty good response. 8 hours, most women are in active labor. It's a wonderful drug. Downside to it, you can't give it to anyone who has a C-section because it can burst the uterine scar. And we don't like to give it to people who are actively contracting. And we don't like to give it to people who have a baby who's not quite well. Because once we put it in, we can't take it out. It's in, it's absorbed, it's in the bloodstream, we're stuck, right? The Foley, I can take it out if it causes trouble. The Cytotec, I can't. And then the last one is Cervidil, also called Prepidil. Cervidil is a prostaglandin inhibitor, or PGE1, and it's on a string. We can put it in the birth canal, and it works just like Cytotec, but it takes a lot longer. It takes 12 hours for each dose, and it's usually the second or third dose. So we're talking 24 to 36 hours of cervical ripening, whereas Cytotec in the balloon, we're talking less than 12. Okay? So it's a much slower method, but it's very safe. I can pull the string and take the medicine out if I want to. It's a wonderful option if I don't trust the baby, if mom's contracting a lot. Some people will use it if mom's had a C-section. But that's how we use cervical ripening. We use Foley bulbs, we use Cervidil, we use Cytotec. And I always say you can't get anything that's good, fast, and cheap, right? Everything has a price to pay. Come on in.
Are you done going over the test?
No. Everything has a price. We're done. We're not going over the test.
Oh, okay.
I thought you said you guys going over the test.
I guess done going
Yeah. But anyway, so there's no such thing as good, fast, and cheap. You always have to give away something, right? So Cytotec with cervical ripening, I say good, fast, and safe. Okay, Cytotec works really well, works really fast, but it's not very safe. Cervidil works okay, it takes forever, but perfectly safe. Foley bulb works really well, works really fast, perfectly safe, but it hurts like crazy. Okay, so there's something to give up with each method of cervical ripening, and understand that cervical ripening, no matter what, increases the risk of C-section. Okay? Oxytocin, bless you. We've talked about oxytocin before from the body's perspective. Now we're talking about synthetically introduced exogenous oxytocin, and it's called Pitocin. Okay? If you're English, you call it Syntocin, which is synthetic oxytocin. But oxytocin is a wonderful drug for doing what it wants to do, and that is make you contract. It is extremely good at making contractions come. But it's also evil. It is the #1 source of complications in American obstetrics, and it needs to be used very, very carefully. So oxytocin is such a dangerous drug that nobody else in the hospital will touch oxytocin. It's one of those danger drugs that you could be in the ICU, on a ventilator, dopamine, dobutamine, keeping you alive, and some obstetrician comes in and says, I think we need to put her on Pitocin. An ICU nurse would say, nope, not in my ICU. Can't happen. Nowhere else in the hospital is allowed to use oxytocin, or will use oxytocin.
I remember in the book it said something about how you normally start with 4 for a pit
Even
drip.
less.
But Cape Fear, their pit drip protocol is 6 every 15 minutes. So why would they use such a aggressive...
It's why I won't let my family go to Cape Fear. It's why I would drive to Raleigh before I took a family member to Cape Fear. So they're using what's called the high-dose PIT protocol. So Pitocin is it's a very dangerous drug, and it plays a lot of games in the head. So we start it at 2 milli-units per minute, and we increase it by 2 milli-units per minute every 15 to 45 minutes. The more, the nursing prefers every 30 to 45 minutes. Doctors are like, I'm in a hurry, let's get this started. And birth is something you don't want to hurry. So it's best to start very, very slow. Now, the therapeutic action for Pitocin is 13. That's when most people will see a therapeutic effect, at 13. So if you're using the high-dose PIT protocol, you'll get there in half an hour, right? Bang, bang, she's on, okay? And that gets mom started contracting like crazy. But taking those large leaps means that you're more likely to have too many contractions. Where if you take the small leaps, you can go up and down by 1 or 2 milli-units and get the contraction pattern just the way you like it. But it takes a lot longer, right? When you're taking the small leaps and you're going up to 13, that's what, 6 adjustments. So that's at least an hour and a half at 15 minutes. We're talking 3 hours if we're talking 30 minutes, right? So WOMAC and most hospitals use the 2x2 protocol, two increases every 2 milli-units every 15 minutes. There are hospitals out there that use the high-dose Pitocin protocol, and it is part of the national standard. It's just my experience, it doesn't work very well. It's more traumatic, and you know how I like trauma, right? How I just absolutely anything that's traumatic, I don't want it. So I never, never, never use the 6x6 protocol. But there isn't a right answer. There really isn't. Okay. But oxytocin replaces, or Pitocin replaces the brain's synthetic or endogenous oxytocin, and it messes with a lot of different stuff. The biggest complication to oxytocin is that we get too many contractions too fast, okay? We talked the other day a little bit about what happens when we have one contraction right after the other, how the baby will complain about it because they don't get rest time in between contractions. And it's called tachycystole. The definition of tachycystole is 6 or more contractions every 10 minutes, averaged out over 30 minutes. So we take 3 10-minute sections at random, and we say, do we have 6 or more in these 3 10-minute sections? Do we have it in 2 out of 3? Then yeah, she's got tachycystole. Okay. The colloquialism for it is hyperstimulation, but that's gone. We use tachycystole. You might hear she's hyperstimming. What they mean is she's in tachycystole. Okay. But tachycystole is very, very hard on the baby, very, very hard on the mother. And so we try to avoid it. So we go up and up and up until we got 5 contractions every 10 minutes. That's about where we want to be. And every once in a while it creeps in and goes up to 6 or 7, and we have to back it back down again. Okay? And so oxytocin is a titration drug. Okay? Now, I've said it for years, and I don't have a lot of evidence to back it up, but if you guys read that review article I gave you on Pitocin, it talked about the deleterious effects of oxytocin on babies, okay? How babies don't like it. Remember, anything I give the mother is going to cross the placenta most times, and it can get into the baby, right? And Pitocin is a bad thing for babies. I think the more we study it, the more we're going to understand it. There will be times, every time I have to put a woman on Pitocin, I give them this speech. I say, I'm about to put you on Pitocin. Pitocin is a wonderful drug. I have a love-hate relationship with it. It works really well. It makes you contract. It does its job. But every time I put you on Pitocin, I expect the baby's heart rate to take a dive for 3, 4, 5 minutes at a time. The room will fill up with people. We'll bark commands. Roll left, roll right, do this, do that, turn this on, turn this off, do this, do this, do this. Hurry up, Mom, faster, faster, faster. And when we do that, we're very rude. Okay? Know that when your baby's heart rate is down like that, I need it to come back up as fast as possible, and I don't have time to be polite. So I'm going to be rude, and then I'm going to apologize about it afterward. Okay? I expect it to happen at least once, if not 2 or 3 times, every single time I use Pitocin on a baby. Okay? I don't think it's the contractions, by the way. I think it's the babies don't like Pitocin. And I think we're going to figure that out over the next few years. But for right now, just know that Pitocin is a high alert drug. It just has all the other safety measures of a high alert drug. Okay? Know that Pitocin causes tachycystole. It's its #1 complication. Okay? And then oxytocin of labor is when augmentation of labor is when we've got labor going, but we want to speed it up because it's stalled or it's slowed down, that kind of stuff. Your book, when we were talking about non-pharmacologic labor support, they talked a lot about why labor would stall, right? And we know why labor would stall in a hospital, because it's just not mom's environment. And it's incredibly common, right around 7 or 8 centimeters, for labor to stall out, okay? Now, I call that the plateau. That's where Friedman's curve gets up and it kind of flattens a little bit before hitting 10. And that's a chance for mom to take a break. That's that 8 centimeter dilated woman who's contracting and their contractions are spacing out, and you encourage her to rest in between those contractions so that she can take it easy a little bit, because she's going to start pushing soon, right? Obstetricians, when they get to that point, say, start the pit, let's keep it going, come on, let's go. And so they use Pitocin to augment the labor. It's not the end of the world, it's just not necessary in my book. But it's okay, but again, it increases risks to mom and the baby when you do it. Now, for moms, important stuff is informed consent. Informed consent is not, this is what we're going to do to you, please sign here. That is not informed consent. Informed consent is a discussion, freely offered back and forth. I would like to do this. These are the risks, benefits, and alternatives. Do I have your permission to do this? Okay. In labor, we usually start with a blanket admission permission that says that we are going to support your labor, but in the case of emergency, we would like to be able to use forceps, vacuums, emergency C-sections, and emergency transfusion, just in case. Because when you're bleeding to death is not the time to say, stop, I'll sign this form, right? So we like to get the stuff, just in case we need it. There's these things in our bag, but we're going to go over it again if we need to. If I feel that we need a C-section, or if I feel that we need a forceps, I'm going to talk to you about it. I'm going to say, hey, so this is what I'm seeing. I really think that if I call the OB in, they could do an operative vaginal delivery and get this baby out fairly easily. We talked about the risks, benefits, and alternatives earlier, and then the OBs come in and they do the exact same thing. Unless, of course, it's an emergency. Then they say, Mom, remember we talked about vacuums? Yeah, we're going to do that right now, okay? Great, we can get the baby out. We don't like to, but we don't like babies that are hurt either. So informed consent is kind of dicey on labor and delivery. Now, there's a lot of people who would say, is there any way to get informed consent on a person who's under duress? Probably not, right? This is someone who we're saying, I know what you think, but I think this, and I got all this training, and I think we need to do it. You can go ahead and do that, but know that it puts your baby at risk and he might die. But it's okay, we can go ahead and do that. Is that informed consent? No, but that's the way most informed consent goes in labor and delivery, okay? They use that your baby or you could die thing, and moms will say anything. You know, it's not quite fair. Other nursing things, a careful monitoring of labor, understanding Friedman's curve, how well the cervix is, how you expect the cervix to change, how you expect contractions to make the cervix change, how, you know, watching how baby's moving down through the pelvis, using your assessment skills, paying attention to the fetal heart rate monitor, how the baby is doing on the monitor, how he's, you know, making sure that he's always stable and relatively reassuring. That's all a very powerful nursing function, okay? Pain relief measures. I think we've talked enough about pain relief measures. I don't have to talk about it anymore. Position changes, I call it bed aerobics, especially with an epidural. Give a woman an epidural, she instantly wants to sit flat on her butt for the next 18 hours. And that makes it very difficult for baby to come down. He can't descend when we've got when we're just sitting in one spot. So I tell him every 20 to 30 minutes, I'm going to be back in here telling you to change position. I want you constantly changing. Left side, right side, sitting up, laying down, hands and knees, squatting, I don't care what, but constant movement all the time. And yes, women with an epidural can squat. Yes, of course they can. Because the knees only flex will only flex so far, and then they lock, right? So you get a woman, you put her feet on the bed, and you lean her forward, and she stops. That's as far as she can go. And they do that on both sides, and you end up with mom, just like this, squatting, because you can't go any further, and all they do is balance with their hands. Right, that enables a woman with an epidural to squat, and they need to squat. Okay, but constant position changes, especially with an epidural. Without an epidural, mom is moving, I promise you. Okay, there's no reason to encourage her to move. She's moving. And then keep women and a support person informed of progress. They always want to know how much longer. And I joke, oh, it'll be 10:53. You know, every time they ask me when I think baby's going to be born, I give an actual number. I do. I'm like, it's gonna be 5:27. And once in a while I'm right, and I look like a genius. And when I'm not right, I just look like I was joking around. Okay? Instrument assistance of vaginal birth. So there are two ways we can use instruments to deliver a baby who's kind of stuck on the way out. Forceps and vacuum. Okay? Forceps, they're in your book. They're long metal objects that go in around the baby's face. Grab them by the cheeks and pull them out. Okay? Vacuum is a suction cup that we put on the occiput or on the vertex, and we can pull them out by the vacuum. Okay? What do you think? Which one is safer for the mother? Forceps or vacuum?
Vacuum.
Vacuum. And which one is safer for the baby? Forceps. Yep. Forceps assisted delivery is much, much safer in the hands of a competent provider. Okay, someone who knows how to put them on, and they literally spend a year learning. There are about 15 or 16 different types of forceps. Each one has its own reason for using it. Some are open with big loops that go around the baby's face. Some are closed and flat. Some are closed and have like little suction cup things on the inside of them. All kinds of different shapes, different styles, different locking arms and locking mechanisms. But when doctors put them on, and only doctors can apply forceps, only obstetricians can apply forceps. They're very, very dangerous in the hands of somebody who doesn't know what they're doing. But they put them up against the baby's head, really high up, and they just kind of guide them and let them kind of fall into place. And the forceps should always just slide into place naturally on the baby's face. They do that on both sides, and they can pull them out. If there's trouble getting forceps in, they need to stop using forceps. Okay? Because there's something wrong. If they don't slip into place, there's something wrong. So when you're watching your doctors do their forceps, and they're like, I can't get it in, you just want to kind of lean in and go, maybe we could try another way. Okay? Vacuums, however, oh, by the way, the biggest problem with forceps is that they're big, okay? And they're metal, and they stretch things out, okay? And the risk of 3rd and 4th degree laceration is remarkably high with forceps. So they often do episiotomies associated with it. It's basically a vaginal C-section. It's just, they need to be done very, very rarely and only in the hands of a qualified person. And then there's a vacuum. Vacuum is safer for the mother, a little bit more dangerous for the baby. Who can think of the big problem we have with baby with a vacuum assisted delivery? Yeah, bleeding under the scalp. Okay, there's a cephalohematoma and all kinds of wonderful stuff. You can cause a bleed in the brain, and the baby will have a stroke and die. Okay, very dangerous for babies. But we apply suction. It's a team effort. The doctor, midwives can do vacuums, by the way. The doctor or the midwife will apply the suction. Will apply the suction cup exactly where they need to. The nurse will pump it up into the green, and then when mom pushes, they give a little guiding pull. Now, neither of these deliveries should the provider be working up a sweat. Okay, we are not pulling the baby out. We are simply facilitating the baby's movement, a little guidance, turning the head the way we want it, that kind of stuff. If they're like, stop them. Okay, they can break the baby's neck. Okay. So forceps are better for baby, worse for mommy. Vacuums are better for mommy, worse for baby. And the rate of forceps and vacuum delivery, it depends on the facility's C-section rate. The lower the C-section rate, the higher the operative vaginal delivery rate is. It's usually about 3 to 7% in a normal hospital. If the C-section rate is really high, you'll find the vacuum and forceps rate is like 0. Because if there's any problems, they just go right to a C-section. Okay? Now, maternal complicted, okay, we have talked about hypertension, I think, right?
Yes.
You don't need to worry about that. Diabetes. The big thing now, we're talking about labor here. We're not talking about pregnancy anymore. Gestational diabetes and type B, CE diabetes, all of these things. They increase the risk to mom and baby just a little bit at birth, okay? So the biggest problem that we have is baby's lungs might delay in how they mature, and so a baby born to a diabetic mom at like 37, 38 weeks might have respiratory problems at birth, might struggle with learning how to breathe. So if we have to induce them, we test fetal lung maturity before we'll do it by taking a little amniotic fluid, and it can tell us whether or not the lungs are mature, okay? So if we're going to induce a diabetic woman before 39 weeks, we always want to make sure we know what the fetal lung maturity is to know that it's safe for the baby to be born. The biggest thing in labor is blood glucose monitoring. Now, 95% of women are called a class A diabetic. They're just diabetic for the pregnancy. They don't need any medications or anything, and they labor just like everybody else. But some women are on insulin before they get pregnant, and those women have more trouble maintaining their blood sugars while they're pregnant, while they're in labor. And so for them, we'll actually start an insulin drip and run insulin continuously the entire labor process. As you can imagine, that is not a safe thing to do. Okay, that takes an awful lot of skill and practice to run an insulin drip in labor. It's very, very small doses, but remember, diabetic women need huge doses of insulin. Why do they need huge doses of insulin in pregnancy?
Because they're making up for the extra.
No.
Because of the baby?
There's a cellular problem in pregnancy. It's mediated by, I want to say, progesterone. No, by prolactin. No. Human placental lactogen, I'm sorry. Mediated by human placental lactogen. It's that pregnant women are insulin resistant. That's why they have gestational diabetes. Because they can't use the insulin that their body is making. Okay? So they use huge doses of insulin when we have to give them insulin. I've given a woman over 100 units of regular insulin. Can you imagine giving anyone in this room 100 units of regular insulin? It would kill them. For pregnant women, I'm like, yep, there you go. That's what you need. So they can use very, very high levels of insulin, and that's why we use insulin drips. We don't use a high dose, but we run it continuously all the way through. Okay? Not done very often, but it can. And then, other than that, the birth is just normal. Okay? Oh, and encourage breastfeeding. As if you didn't need to already encourage breastfeeding on every single person you meet, you encourage breastfeeding because diabetic babies tend to be, or mothers who are diabetic have babies who come out and their blood sugar drops. Why would a baby's blood sugar drop if his mother was a diabetic?
Because he's not getting the sugar.
Because what?
Because he's not getting that load of sugar.
Exactly, because a diabetic woman has very high sugar because her body is insulin resistant. The baby's body is not insulin resistant. So the baby's body produces high levels of insulin in order to compensate for the high blood sugar coming in from his mother. Okay? When the baby is born, guess what? That high blood sugar coming from his mother is gone. And he's still producing high levels of insulin, and his first couple blood sugars can be really, really low. Okay? But mothers who breastfeed, especially diabetic mothers who keep the baby skin to skin and breastfeed immediately, have babies who do not have blood sugar problems. So the more we can keep the two of them together, the better it is. Okay? Preterm labor. So we've talked a little bit about preterm labor, but we're talking now a woman who's in labor prematurely. Okay? Labor progresses pretty much like a normal labor. They tend to be a little faster, and big surprise, they don't ever have to make it to 10 centimeters dilated to deliver. Why not? Why would a premature baby deliver at 7 centimeters? Because he's so small, right? Their little head is only like this big. They don't have to get to 10 centimeters dilated. And so what happens all the time, especially with novice nurses and residents instead of experienced providers, is they go and they check her and she's 6 centimeters dilated, and they're like, oh, I'll go get some dinner because she's only 6 centimeters dilated. And then at 7 centimeters they deliver. Happens all the time, okay? The 28, 29, 30-week babies and the fetal demises at 28 to 32 weeks are very, very small, and they don't get to 10 centimeters dilated, and they surprise us. So it's important to understand that. The other trick is, whatever caused the preterm labor in the first place, oftentimes means the body doesn't want the baby there anymore, okay? And so women who are sick in labor, they labor pretty darn quickly. I've had hypertensives deliver 20 minutes after I started their induction. That just ruins my day. Because I'm not there. I'm like, okay, take this, I'm going to go grab some food, and they go from 0 to 10 centimeters and deliver in 20 minutes. It's ridiculous. Because the body wants to get rid of the baby. Abruptions, hypertensives, premature births, they tend to deliver very, very quickly. Okay? So the big problem, so we want to be very careful and monitor what they're doing. We want to use careful fetal heart rate monitoring because premature babies are not the same as term babies. They're not strong like term babies. They can't handle the labor sometimes, and they struggle with birth. So we have to be very careful on our premature babies when we monitor them. And then, of course, psychological status of the mother is very important. Because what happens when a woman has a 25, 26, 28-week baby? Does she have the normal birth that she was expecting? No. Absolutely not. And is it all going to be over in 48 hours and she'll go home like everybody else? No, she's going to spend the next 3 months in the hospital, okay, with a baby who's got 50 to 75% chance of survival, okay? You think childhood cancer is bad. 27, 28, 30-week babies are bad, okay? And they're sick for a very, very long time. One of my freshmen that I'm teaching this semester, she was born at 28 weeks, and so I was talking to her about her first, 5 or 6 years of life. She had 18 bowel surgeries for necrotizing enterocolitis, had a colostomy. She had a rough time in the first few years of life because she was born prematurely. She survived, right? She's a college freshman, but it was a rough few years, okay? And so women who are delivering babies prematurely, especially micro-preemies, less than 30 weeks, are in for a long, long struggle. And so it's important to remember that. Now, fetal complications that make birth interesting. Fetal malpresentation is fairly common. The most common would be like a breech or an occiput posterior, but they can come down in all kinds of funny positions. Remember we talked about ROA, ROP, ROT, all that wonderful stuff? What do you think you call it when they come down like this? Leading with their left ear, or leading with their right ear, or leading, with the cheek, or that kind of thing. They're odd. It's called asyncliticism. They come down just a little crooked. They're asynclitic. They're not in sync with the pelvis. That's perhaps the most common of all the malpresentations. They'll usually fix themselves, but they come out with this giant cone head off the side of their head. And so when you're in a nursery and you're watching your babies and you're looking at all your babies' heads, look at where the cone is. That tells you what their presenting part was. They'll come in, most of them will have a cone shaped toward the back, but they'll have it off over one ear or over the other ear or in the forehead or all kinds of interesting positions. Okay? Now, if they're breech or transverse, a doctor can turn them, okay, from the outside. They kind of lift the head this way, push the hip, but they kind of turn it that way and turn the baby around. What do you think about the risk factors for external cephalic version? What do you think they would be? External cephalic version. If you had a baby who was breech, and we were going to turn them from the outside to come head down. Cord prolapse could be if the water breaks, but what? Entangling in the cord? Yeah. Yep. One of our docs won't do an external cephalic version if he sees a nuchal cord on ultrasound. There's not really any reason not to, but he won't do it. It just increases the risk. The biggest one we worry about is placental abruption, that we knock the placenta off the wall while we're doing it. So when you do an external cephalic version, you always have to be prepared for an emergency C-section, which is why we don't do them at home, which is why midwives don't do them, because you have to be able to do an emergency surgery immediately. So we get everything set up for a C-section, and then we do the version. And if it works, great, then we just go home. But if it doesn't work, then we go right into C-section. Okay? Shoulder dystocia. We talked about shoulder dystocia a little bit on our first day, when we were first day in the lab, and we talked about the baby who gets stuck. So shoulder dystocia is an obstetrical emergency. It is almost exclusively handled by the provider, but they need a team of nurses to help them. And do you guys remember what we do for shoulder dystocia? There are 2 maneuvers that are very, very important for the nurse to know. This one, right? Yeah. Where we had to have Rachel on a stool so she could get upright. That's called suprapubic pressure. Okay? The object of suprapubic pressure is to get the baby behind the shoulder and push that shoulder down underneath the pubic bone. Okay? So the provider will usually say, I want suprapubic pressure there going that direction, or here going that direction. And you press in and you push that shoulder down underneath the pubic bone. You've seen it?
I saw it at C-section.
In a C-section?
Yeah, because they couldn't
Mhm.
Because from the, like from.
On the top.
Yeah.
Yeah, that's a different thing. That's not suprapubic pressure. That's fundal pressure. And if any of you ever do fundal pressure in a vaginal birth, I will come back and haunt you from the grave. That is an evil, evil thing. Don't ever do that. It just makes it worse. Old doctors will sometimes, give me a little fundal pressure. Your answer is no. Your answer is no, thank you. I like being a nurse. You can do whatever you want, doc, but I'm not doing it. What they used to do, they used to think if the shoulder was stuck and you push from the top, you can push the baby out from the top. But all it does is get their shoulder further dug into that pubic bone and they can't get out. So it's not fundal pressure. It's suprapubic pressure, and it's at an oblique angle just above the bladder. Okay? And then the other one is McRoberts position. What is McRoberts position?
Wasn't that when you went from underneath? No.
It has to do with mom's legs.
Oh, up by the floor.
When you bring those legs all the way back, yep, legs up and back and get their butt up off the bed. Push them all the way in, and it opens up their pelvis. All it is an exaggerated squat position, but with her lying on her back, it's just this, okay? But it's magic. The combination of suprapubic pressure and McRoberts position will resolve 95% of shoulder dystocias almost instantly. It's a wonderful thing, okay? Cephalopelvic disproportion, any idea what that is?
That's when the pelvis is not proportionate to the head.
Right. The cephala and the pelvis just don't quite match, right? It's when the head and the pelvis don't play well together. Either the head's too big, pelvis is too small, the head is square and the pelvis is triangle, whatever. It's just you can't get a square peg through a round hole, right? And then multiple gestations, that means twins, triplets, that kind of thing. And then non-reassuring fetal heart rate patterns. By far the most common complication we'll see is non-reassuring fetal heart rate tracings. Those are those late decels, repetitive variables, the minimal variability, those kind of things. Amniotic fluid complications. Who can tell me what oligohydramnios is?
Not enough.
Not enough fluid, exactly. Oligo meaning not enough, hydramnios meaning water, right? Not enough water. Why is oligohydramnios a big deal?
Because it doesn't.
Not cord compression.
Because it doesn't give baby temperature.
Nope. What is oligohydramnios? What is amniotic fluid?
That's the nutrient.
No, not nutrient.
That's his
Not
tiny
hydration,
cushion
not
and cushion.
temperature.
That's his pee.
Where does it come from? What?
It's the little baby's pee.
It's baby pee, okay? It's not really waste, it's just baby pee, okay? The waste goes through the placenta. The amniotic fluid is fine, okay? The kidneys aren't filtering blood, they're just practicing in utero. But it's baby's pee, okay? So the baby makes the urine and pees it out and learns how to make his kidneys and his urinary system work. But what happens in a grown-up who got in a car accident and isn't making urine? What is it? Kidney failure, right? And why do the kidneys fail? Because they can't oxygenate, right? Remember we talked about our postpartum hemorrhage drill? We talked about using the urometer on your Foley bag because urine output is a marker for kidney function, and kidney function is a marker for shock, right? That if you start to go into shock, you have hypovolemia, hypoxia, your kidneys are going to shut down first, right? The exact same thing happens in babies, okay? A baby in the womb who is under some form of stress, who is hypoxic, who's not growing well, is going to stop peeing. And his amniotic fluid is going to drop, okay? Because he absorbs it, but he can't pee it back out again because his kidneys are shutting down, okay? So when we're doing our ultrasounds, we can measure how much amniotic fluid is there, and then we do what's called an amniotic fluid index. And the amniotic fluid index should always be higher than 5. Okay, if it's 5 or less, then that's a sign that there might be something wrong with the baby. We need to do more testing. And when we do our antepartum fetal testing, because we're worried about moms and babies, we do a non-stress test and an amniotic fluid index every 72 hours. A non-stress test every 72 hours and an amniotic fluid index every week. And those two together reassure us that baby's doing pretty well. Okay? Other problems, they put the nuchal cord under fluid complications. I guess it doesn't really belong many other places. What is a nuchal cord? Cord wrapped around the baby's neck. And what does it mean?
There's potential to cut the oxygen supply.
Okay, how would it cut the oxygen supply?
Because as the baby descends, if the
Uh-huh.
cord is still wrapped, it'll become tighter.
No,
Okay.
I think you said.
And if it gets tight around the neck, well, then what happens? He'll choke?
Well, the
That's
oxygen's
the
coming
way
from
the
the,
oxygen comes from the cord, so
umbilical
if it,
cord.
isn't it like if the cord is tight, then it
Uh-huh.
won't, like.
Exactly.
the oxygen flow.
A cord around the neck is no different than a cord around the wrist, or a cord around the ankle, or a cord around the shoulder. It's not really nuchal cord that's troublesome. It's a cord that's tangled somewhere where it doesn't belong. But everybody sees nuchal cord and they freak out like the baby's going to choke to death. Babies aren't breathing. They can't choke to death. It doesn't happen. Okay? But what happens is when it pulls tight, blood flow is restricted through there. And the biggest problem with nuchal cord is that it's a dog on a leash, right? And they're trying to come out and it's pulling back on them and they can't get out. Okay? And that can make some trouble. The easiest way to fix a nuchal cord is to ignore it. I was talking to Donna about this when she was here visiting with us, and she says they don't even check for cord. They don't even bother, because you just ignore it and it's fine. But we're taught to deliver, we check for cord, and then we either pull the cord up over the baby's head, or we slip it down over the shoulder, which is why she just ignores it. If she finds a cord, she just slips it over the shoulder, who cares? When it's really tight, you might notice a midwife do something called a somersault maneuver. We just turn the baby's head to the thigh, and the baby will flip out like he'll somersault out, and the head stays in one place and the body comes flying out. It's a pretty neat little trick. But one thing you never want to do, and doctors like to do this because they think it's easy, is to cut the cord before the body has delivered. They'll cut the cord like the head will come out, they'll get a tight nuchal, they'll cut it right there, and then they'll deliver the baby. Now there's two reasons I don't like doing that. One, obvious, right, because it's not delayed cord clamping, right? The other is, what if I then get a shoulder dystocia? Now I've got a baby with no oxygen supply, okay? And I'm in trouble. So I try not to do that. That just takes too long. The baby will just be born anyway, leave him alone. Placental problems. Placenta previa, placental eruptions, we've talked about these enough, right? And what is disseminated intravascular coagulation? We talked about it during our postpartum hemorrhage drills. Something with clotting, good. It's when mom all of a sudden starts bleeding out of her eyes, ears, mouth, nose, and she just bleeds to death in front of you.
Oh, isn't that one you? Because I thought it was weird because you give them heparin.
You do, that's the one you give them heparin, exactly. And did we explain why?
Shut it down.
Because it
please.
shuts their.
It shuts down the clotting cascade, and it allows the body time to rejuvenate and reform all the clotting factors that it needs. And then once the clotting cascade is kicked back in, it's got all kinds of backup. But DIC is a complication of severe hemorrhage or maternal hypertension. It is the last thing you see before they die is DIC, okay? In every woman I've heard about who's died in labor, it ends with DIC. Okay, it is the terminal illness. But it's a complete shutdown of their clotting cascade. They're trying like crazy to do it and they can't. And they'll start to bleed out of their IV. They'll bleed out of their nose, their eyes. They just bleed from every mucous membrane and they bleed to death.
So the heparin does not stop that then, or does it?
What happens is heparin shuts down the body's ability to even try to make clots. So they continue to bleed, okay? And then you pack them full of fresh frozen plasma and crystalloids and platelets, and then like 20 minutes will go by, and then the heparin will start to wear off, and then they'll have all these clotting factors that can now go in. So it's kind of like in a military maneuver, you'd retreat to a more defensible position, get your reinforcements, and then attack back. That's basically what we do, is the heparin allows the body to retreat for a while. They're going to continue to bleed, right? But we're going to support that. But if we don't, they'll just continue to bleed to death anyway, and there's nothing we can do about it. Other complications, uterine rupture. Uterine rupture, when do you think the uterus would rupture? What's the highest risk of uterine rupture?
Overdue?
Not overdue.
Multiple gestation.
Nope. That is one of them. The number one thing, the one we see it more often than not, prior C-section, exactly. Once we've done a C-section, once we've damaged the uterus in any way, it's no longer as strong as it used to be, okay? Now, when you do a low transverse C-section, we go under the contractile portion of the uterus, we cut basically into the top of the cervix, your chance of a uterine rupture is anywhere from 0.5% to 3% in your subsequent labors. That's pretty good. I can live with a 0.5% risk, okay? I'll take that risk any day if I have to. Now, if you cut through the contractile portion of the uterus, do what's called a classical incision, straight up and down, your risk is 50%, okay, in labor that it's going to rupture. Same thing with myomectomy, same thing with any uterine surgeries in the contractile portion of the uterus, they tend to rupture, okay? It used to be once you had a C-section, all births had to be by C-section after that, okay, because they did classical C-sections. Then we started doing our low transverse C-sections, and we found, guess what, you could safely labor after a C-section. And 80% of women in America today who have a C-section on their first birth, who attempt a vaginal birth, will have a vaginal birth the second time. 80%. That's a really high number, okay?
Even after a classical C-section?
No, not in classical C-sections, absolutely not. Only with the low transverse, okay? But to do a vaginal birth after C-section, you have to have anesthesia and a surgeon on standby, ready to do a C-section in the next 15 minutes. You have to be prepared for it. So most birth facilities can't offer that kind of support. So a lot of birth facilities still request them to do a C-section or to travel to a tertiary center and labor in the tertiary center. Here, WOMAC and Cape Fear both do VBACs. WOMAC's VBAC success rate is higher than the national average vaginal birth rate. It's pretty darn good, okay? It's up in the high 80s, which is pretty nice. And that's because we have 24/7 OB, anesthesia, midwife. We have somebody there constantly to take good care of them. So we're set up for VBAC. We do it pretty well. Uterine inversion, I have never seen one, knock on wood. But what do you think a uterine inversion is?
It's inside out.
Yeah, when the uterus goes inside out. Now, from what you know about uteruses, is that a good thing? No, because it can't contract and close those blood vessels off, right? And so what happens is the uterus, you know, it's just a bag, right? Think of it as an old worn out sock, and it just flips inside out, okay? The great news is all you gotta do is push it right back in. You just push it back in and tighten it up around your hand, and it'll tighten back up again. We often will give nitroglycerin to relax the muscle and allow us to put it back in. They bleed like crazy when you have a uterine inversion. The most common is where the cervix stays in place and the fundus comes to the cervix. And those are, you know, they kind of like make a little dimple, almost like it's trying to make a donut with a hole in the center. You know, you can just push those back up and tighten it back down again. But uterine inversions bleed like crazy until you get some fundal tone. And then umbilical cord prolapse, what do you think that is? You've mentioned it a couple times. It's a risk when you have breaches. It's a risk when you have multifetal pregnancies. It's a risk when you have polyhydramnios. Yeah, when the cord comes down before the baby, okay? And what do you think happens? The cord comes down before the baby. Now we've got a cord dangling out where it doesn't belong, and it can be really easily squeezed. And because of the way babies are born, that big head closes everything down, right? And so what happens is the head comes down, the cord comes down, and the head goes up against it and blocks it completely so the cord can't work. Also, interestingly enough, umbilical cords tend to spasm when you touch them. And so if you grab one and try to push it back in, it'll spasm on you and close down blood flow to the baby. So what do you think the treatment is for a cord prolapse?
I just like cover it and go to the OR and do
Yeah.
C-section.
Yeah. Emergency C-section. What you actually do, if you're the provider, if you are the healthcare professional who was unlucky enough to discover the cord prolapse, here's what you do. So you're checking mom, and you're like, oh, mom, I got a cord prolapse. Climb on the bed and hold the cord, and don't let anything touch it, okay? You make a little channel or with the cord lying in your hand and try to keep the baby's head away from the cord. I find it works best if I go above it like that and put the baby's head up against here, and I can protect the cord between my fingers. And you climb on the bed and you go along for the ride because you're not getting away until the baby's born. And they'll just cover you up in the operating room and you're in there and you'll feel their fingers down around as they get the baby out, and then they can close everything
So
up.
are you speaking from experience?
Yeah.
That's happened?
Yeah. Yep. It's a fun ride. It's one of those things you tell stories about later. I've seen 2 cord prolapses. One, and I was stuck there for a very long time because I was in Watertown and my surgeons were like 30 minutes away. So I was like, cord prolapse, quick, call me some help. My help is 30 minutes away in a snowstorm. So I was like, call any surgeon in the hospital. They don't have to be an obstetrician. Anybody. Call every surgeon who works here. Get them here immediately. And like in 5 minutes, one of the other OBs who happened to be closer was able to come, and he helped me out, and we got the baby out. But you can't move, you're stuck, okay? The best thing you could do is get someone else to take your place, but that's kind of rude. So you're just like, okay, I'll just wait, and hopefully baby's doing okay. The other cord prolapse I saw, I was training a midwifery student, and this was a woman's 4th or 5th baby, and I would talk to her about, okay, so we're going to rupture her. She's at like 9 centimeters dilated. We're going to break her water. And what do you think we would do if she had a cord prolapse at this point? And she's like, well, the right answer would be to do an emergency C-section. I said, okay, but this is a mom who's having her 5th baby at 9 centimeters. You could probably just push and get that baby out like in a minute or 2, right? And just deliver it through the cord. Oh, yeah, I guess we could, maybe okay. And then so she broke her back, and I was kind of sitting back like I normally do, sitting on my trash can, right? And baby was doing fine, everything was wonderful. And I was like, what's that thing sticking out of her vagina? What is that? And the student was sitting right there, pushing with her. And I was like, is that the baby's head? I can't, what is that? And I finally got up close, and sure enough, it was the umbilical cord sticking out of the birth canal. And I went, what's that? And she looked at me and went, it's the cord. Midwife, you're going to graduate in 2 weeks and you didn't respond to a cord prolapse? She failed, by the way. Gone. Out of midwifery school. She does not get her license. But we pushed twice, delivered the baby, and we were okay. But I mean, it was all I could do not to hurt her. Get out of the way. Because you can't ignore a cord prolapse.
You should get a retry at least.
We were her retry.
Maybe she can be
That was the second chance.
Whatever she wants to be, it's not going to be a midwife. Because that's how you have people who are unsafe, who hurt people. If she can't recognize that, if she's the one that freezes under pressure, I don't want her, okay? Just like being a pilot, you can't freeze under pressure. You got to move. And some people just aren't meant for the job, and that's okay too. Get out and go be a labor and delivery nurse or something, but not a midwife. All right, variation in the umbilical cord. Velamitous insertion, very similar to a vasa previa, which we discussed briefly on the test. And that's where the umbilical cord, it's normally this twisting cord that goes right up against the wall of the abdomen. But in a velamitous insertion, the twist stops a few inches or a few centimeters from the placenta, and it comes down, kind of like, what are those trees, the poplar trees down in the south that just stop above the ground and the roots kind of come out?
The cypress trees?
Cypress trees, okay, those trees. They look just like that. Just like the tree trunk stops a few feet off the ground and then it goes down. That's what a velamitous insertion looks like. Okay, and a vasa previa is when that velamitous insertion happens and the vessels go through the amniotic sac to the placenta. We almost always discover both of those after the baby was born and go, ooh, look at that, that was lucky. So these are placental variations. This is the velamitous insertion. And what do you think is the problem with this? Little fragile, maybe?
Yeah.
Yeah, a little fragile. And what will happen is everything is fine, the baby delivers, life is good. When we try to deliver the placenta, we tug a little bit, and those vessels break. And then we have to go manually grab the placenta and bring it out. A circumvallate placenta, it's really just interesting, is all it is. The amniotic sac folds in on the placenta and then comes out again. So it's got like this ring around it. And if you look at every placenta born, you'll see a lot of circumvallate placentas. The greater the degree of circumvallate, the more likely they are to deliver prematurely. But we would never know it. You can't see the circumvallate placenta until you deliver them. So it's always just oh, isn't that interesting? This is a succenturiate placenta. You have your main placenta, and then you have a little lobe off to the side. These are tricky because, you deliver the placenta, and you're like, why are these blood vessels heading off in this direction, and then they break? Because you left the other piece back inside, okay? Oftentimes these are associated with what used to be a twin pregnancy, okay, where there was at one point 2 placentas, and one developed and the other didn't. And then this is my favorite, battledores placenta. Battledores placenta, I always say it's just like Harry Potter, Dumbledore's placenta,
I
right?
was just thinking.
But Battledores, it's just, what's that?
I was just thinking that, but I didn't want to.
Yeah, that's fine. No, Battledores and Dumbledores. The placenta that we use in our sim lab is a Battledores placenta with the cord off to one side. It doesn't mean anything, it's just interesting. Then there are 3 types of placentas where they grow into the uterine wall. Placenta accreta, placenta increta, placenta percreta. Accreta is the best. Increta is where it goes into the myometrium. Percreta is when it goes all the way through to the other side of the uterus, out into the abdominal cavity. All 3 of them usually mean mom's going to have a C-section. Mom's going to have a hysterectomy. Because when the placenta grows into the uterine wall, you can't get it out. I have heard of placenta accreta being able to rescue the uterus with the placenta accreta, but I've never seen it. It's almost always, they just continue to bleed until they bleed to death, or you do a hysterectomy and save it. Yes, ma'am?
What was the first one again?
Accreta, placenta accreta.
Oh, the pictures.
Oh, velamentous,
Development.
succenturiate, I'm sorry, this is succenturiate. This is circumvallate, succenturiate, and battledores. This is, of course, right in your book. Okay? And these placental anomalies, the accreta, increta, percreta, happen most commonly as a response to C-section. It's when the placenta implants at the uterine scar, and it can grow in and myome and invade the scar, and then it grows into the uterus. Amniotic fluid embolism. Amniotic fluid embolism is DIC on steroids. Amniotic fluid embolism, and we don't know exactly why it happens, and we don't even know exactly what it is. The theory is, as the name would imply, that some of the baby's amniotic fluid gets into mom's vascular system. And since baby's DNA is not mom's DNA, the body does this entire body of graft versus host rejection. Mom has a metabolic meltdown and dies very, very quickly. They happen about 1 in 50 to 1 in 80,000 births, and the survival rate is about 20 to 50%, depending on what level facility you are in. If you're at WOMAC and everybody is lined up just right, you have about a 50-50 chance of living. If you're delivering at home or delivering in a birth center, your chance of survival is almost 0, because you'll be dead before you can get in the ambulance. It's a very, very dangerous thing. I've seen it happen once, and I reviewed a morbidity report on one where it happened. The one, interesting enough, the one where it happened, it was my patient. She came in at 9 centimeters dilated, huffing and puffing and just dying. And I was like, good job, Mom, we're almost there. We just push, we'll have a baby. No, I need an epidural, I need this. Come on, we can do it. It's your second baby. Just push, we'll have a baby. No. Okay, fine. So I called for the spinal. Anesthesia came in. She was lying on her side, did the spinal. When she rolled over on her back, she was white as a ghost and completely non-responsive, blood running out of her nose. Uh-oh. That's not good. So I turned to the nurse, because anesthesia grabbed the ambu bag, did the sternal rub. I turned to the nurse and said, get me some help. And she was gone. I was like, oh, all alone. So I was like, oh, fine. So we're going to start compressions on this woman who is now dead on the bed with a baby inside. And it turns out what the nurse did was she recognized the amniotic fluid embolism and ran and got help. And so the OB came in, the baby was crowning. We delivered by the vacuum really fast and ran off to the ICU, and she survived. She took all the blood we had in the hospital, and she was in the ICU for like a week, and she survived. She had no memory of the event. 6 years later, I was working in the OB clinic here at Fort Bragg, and our clinic NCOIC, you know what the NCOIC is?
Yes.
Yeah. Our clinic NCOIC came up to me one day and said, you were my midwife when I had my baby. And that happens all the time. Oh, that's nice. When was that? And she's like, yeah, I'm the one who had a DIC. Or I'm the one who had amniotic fluid embolism. You could have knocked me over with a feather. Kid was perfectly healthy. Life is good. 6 years old. He's happy. She had a little cognitive problem because she was hypoxic for a little while, but not enough to kick her out of the army or anything. But yeah, and she was pregnant again.
Oh, that's your lollipop story.
Yeah. Only 10 people, it's only been recorded in medical history 10 times that somebody had an amniotic fluid embolism and then had a subsequent pregnancy. It's only been written up 10 times. We were totally clueless, had no idea what we were going to do, and then she transferred to San Antonio, damn it. So,
Y'all recommend that? Like,
no.
oh. I mean, I guess you can't help it in the
Yeah,
process.
people get pregnant, they get pregnant, right? But no, we don't recommend it. And it's just because we don't know what's going to happen. You know, it's only been written up 10 times. And I think it was kind of like hit and miss. Like half of them had an AFE and the other didn't or something like that. But yeah, we don't know. Lollipop story? I don't remember a lollipop story.
Oh.
That was
No,
so
we didn't
laughable
about that.
story where somebody remembers you years later about
You
how
had a
you
big
touched
impact
your-
on your life.
Yeah.
It's a TED thing.
Take off.
One of those.
Oh, and Ted, oh, okay.
That Professor Behringer showed us today.
Oh, okay, okay. Because I was thinking, I don't remember telling stories about lollipops. Well, one of the problems, well, it's both a blessing and a curse with being in obstetrics is you get that you were made a big impact on my life 3-4 times a month. It's very common. I can't go anywhere without somebody going, "Oh my God, it's Tom!" And you know, happens all the time. But now, fetal loss, and then we'll stop because it's 4:30. Okay. I promise. If you spend any time in obstetrics, you are going to deal with an intrauterine fetal demise. Okay. It happens that about 1% of all babies in the 2nd or 3rd trimester will die for no apparent reason. Okay. We just don't know why it happens most of the time. It's not a chromosome anomaly. It's not a cord accident. It's not an infection. They just die for no reason. And it is very, very painful, okay? It's painful for the family, of course. It's painful for the nurses who have to take care of it. It's painful for the providers who have to deliver them. It's painful for everything, okay? Because we don't come into obstetrics thinking about death. We come into obstetrics thinking about life and how beautiful and how wonderful it is. And from the moment the pea hits the stick for the rest of your life, you're different, okay? You become a mom almost immediately. And when you go into 32, 36, 38 weeks, planning on your healthy vaginal birth, and then your baby dies all of a sudden, it's a major blow. Not only is it painful, but it's not only is it the loss of that baby, Joey died or whatever, but it is much worse because it's the loss of motherhood. It's the loss of fatherhood. It's the loss of Christmas and New Year's Eve and birthdays and riding ponies and baby hats and all that stuff, okay? It's a loss of the entire life. And it is horrible, horrible. And it's the reason why I got into obstetrics in the first place. I was a surgical nurse, and I was taking care of patients who had miscarriages, and I became a perinatal bereavement counselor, and that work pulled me into labor and delivery, taking care of grief for women who were losing babies in their 2nd and 3rd trimester. Because in a place like Womack, it happens 3 times a month. 1% is 3 times a month in a place like Womack, so it happens a lot, okay? Big things for nursing. All the labor has to happen, okay? The labor and birth and postpartum process is exactly the same, okay? They get induced, they have cervical ripening, they get epidurals, they have postpartum hemorrhages, they do all the stuff, okay? And that's all there. And it's difficult to go from happy, wonderful, helping room 5 have a baby to not happy and wonderful, helping room 4 have a baby because they've lost their baby. Obviously, we don't use fetal monitors for IUFDs. We're not trying to listen to the baby's heartbeat, of course. And then they tend to have more postpartum hemorrhage. Okay? Now, what to say and what not to say. What do you think of some things that you would definitely not want to say to a woman who's just lost a baby? You can have another one. Oh, never say that. You're still young. Don't say that.
Everything
Okay?
happens.
Everything happens for a reason. Oh, my sister had 5. It's okay. Right. Never, never, never. What do all of those things do?
It decreases the grief that, or it depletes it,
It devalues it, right? It doesn't validate, it devalues what they're thinking. It says that you don't have a reason to be sad because we can make excuses for why, okay? Because you can always have another one, like that matters. I don't want another one, I want this one. His name was Bobby, another one is you have an angel in heaven. I don't want an angel in heaven, I want him here with me, okay? So none of those things, while they sound nice, they don't work, okay? And the worst are friends and grandparents. They are the worst, okay? Because they want to protect you, and they want to keep you safe from your grief and not allow you to feel it, right? And so it's awful, awful stuff. Things that you can say. What do you think?
Sorry for the loss of Bobby.
I'm sorry that you lost Bobby. Exactly. What another one?
Well, if you need to talk about anything, like know that I'm here?
Exactly. I'm here for you and I want to listen. What I do when I have a fetal, an intrauterine fetal demise, it's called IUFD, by the way, intrauterine fetal demise. I take off my watch and I tell people I'm going into room 5. Don't call me unless somebody else is dying. And I take off my watch and I go and I sit down and I start with, can you tell me what happened? And you hear, well, you know, everything was great. We had a normal pregnancy. And then like yesterday, he was moving like crazy and then I didn't feel him move again after that. And then I started to get worried. And then I came in this morning and they did an ultrasound and they couldn't find his heartbeat. And the interesting thing is that the more you talk about it, when you first start talking about it to a mom and dad, they'll say everything except he died. They'll say, and they couldn't find a heartbeat, and I didn't feel him move, and they said that he wasn't there, and they said, and they never say, and he died, okay? And then eventually you'll hear, and he died. But it takes a while to get that, make that happen, 8, 10, 12 hours, 2 days before you hear, and he died. That's, for some reason, a very powerful thing that moms and dads have a hard time saying. But what's important is a little anticipatory guidance. This is a severe, acute grief response. And for the first 2 weeks or so, they're numb. They can't think, they can't hear, they can't nothing. It doesn't matter, okay? They can't process anything. So it's a little bit of just know that this is going to happen. And all I want is to know that you can eat a little bit every day. All I want to know is that you can sleep a few minutes every day. And it'll get better over a long time. And eventually you'll have more good days than bad days, and that's all I can expect. And it might take you 6 months, it might take you 6 years. I have no idea how long it's going to take. But eventually the goal of therapy for an intrauterine fetal demise is you'll have more good days than bad days. Okay? Now, what nurses do, after all of that, we help mom have a baby, mom and dad have a baby, and I still call them mom and dad because they are still mom and dad, although I've had 1 or 2 get mad at me for that. But they are still mom and dad. The reason they're grieving is because they're mom and dad. But after they've had a baby, is you immediately give the baby to mom and dad to hold and to love and to cuddle and to take care of. And we bathe the baby and we take pictures of the baby. And we collect mementos. We make little handprints and footprints out of clay. Everything that touches the baby, we give to mom and dad in a little box, and they can take it. And they say things like, I don't want them. I go, that's fine. I'll keep it. And you might want it 2 months from now, and I'll have it here for you.
Have you had parents come back and?
Oh, yeah. Almost every one of them. Oh. Yeah. They very rarely ever refuse in the long run. First, they always take it. The very few who refuse come back in a month or 2 and want it. Okay? But it's an incredibly painful thing. But it's the only memory that they have of their baby. And from somebody who's never lost a baby looking at it, it looks morbid and downright like awful to see pictures of people holding dead babies. But to mom and dad, this is their perfect baby that they've been dreaming about for months or years. And it doesn't matter how they look. They love them like crazy. Okay? And so, so important things are to understand what not to say, what to say. Don't be afraid, they're not going to hurt you. Okay? But it is hard and painful to walk in that room. And if you get a chance, I highly recommend going in the room. Okay? Because it can be a moving experience. It's some of my favorite stuff is to be able to help like that. It's when I can do the most with so little effort. You know, sure, it's wonderful to help people have babies, and it's wonderful once in a while you get to save a life. But when you get to save their future by helping them work their way through the grief and make the next 10 or 15 years of their life better, I think that's much more valuable.
I got to go into a room, my very first day on the L&D floor. I got to go into a room. The mom was 21 years old. She had just gotten married. I don't know if they got married because she was pregnant or what, but she was really young. She was only 29 weeks. And I was going in there like I had no idea. My nurse didn't really tell me because she was brand new too. I don't know what her deal was. But we walked into the room and I just kind of, my eyes got huge because it was an IUFD, like the baby was passed, but we still had to, you know, proceed. We had to induce labor. I had to do the vaginal suppository, like everything. She had to deliver her baby, and the midwife was kind of like what you did, like take the clock off. I don't care what's going on. She's been in there and she was crying, and I got to hug the whole family and everything. It was. I mean, for it to be my first day too, it was just kind of eye-opening to go from seeing a C-section in the.
That's rough on the first day.
It was.
All right. Only 2 more slides, but we're up to 4:30. It's been a long day. Go on.
It's been a long day.
Tomorrow, by the way, breastfeeding symposium, room 104, 8 a.m.
Scrubs, no, scrubs from 104.
The other room. This is 103, that's 104.
Oh, we gotta be sitting on top of each other.
Scrubs.
Oh, and then we gotta move again.
Did we already discuss this, scrubs?
Gotta try to not break up.
What?
What are we wearing?
Whatever you want. Fine.
Oh,
Just like-
we're gonna wear whatever we want tomorrow?
Whatever you want.
Really?
Yep. As long as it doesn't get me in trouble with Miss Matthews.